we're going to move on to a case study, which is the first case study that will be presented at this ACS forum, and I'm going to ask Miklos Rola to present his case.
A warm welcome to the audience. I'm looking forward a lot to present you an unusual ACS case. There is a young female patient, 19 years of age, presenting to the emergency department with dizziness and sudden onset chest pain that started 3 hours before. She has no significant prior illnesses. She doesn't smoke. She has a negative family history, and she uses an intrauterine device for contraception. I will give you a few seconds to appreciate her ECG. You can see very slight ST changes in lead 3, maybe AVF, slight elevation, and some STT changes in the anteroseptal leads. This is her bedside echo. She has no regional wall motion abnormalities and a normal systolic function. And this is my first question to the audience. We're already having a first troponin coming in, which is slightly elevated. And I would like to ask the audience, what is the strategy that you would try to prefer in this patient? Would you want to go for a high-risk approach, as we just saw in the recent NSTEMI guidelines, angiography within 24 hours? Would you go for selective invasive because you think this is an extremely low pretest probability for an ACS? Or would you even go for non-invasive because, again, very low pretest probability for an acute coronary syndrome or a myocardial infarction? Let's start the poll. 50% voted to go for an angiography within 24 hours, and the rest of the 50% would like to go for a lower risk approach, 30% for selective invasive and 19% for non-invasive. Let's move on. And I have a second question for the audience. For this very patient, how would you treat her? Would you go for administering some antithrombotic therapy? Would you use only aspirin? Or would you go for a dual antiplatelet therapy in this patient? Let's start the poll. So 6% would not give anything, 37% aspirin only, and even in the light of the recent guidelines, 57% would give dual antiplatelet therapy, so aspirin plus a P2Y12 inhibitor. Let's move on and see what happened next. So we were able to offer this patient a pretty rapid angiography. And what I would like you to appreciate here are nice left coronary artery, LAD without a problem, circumflex without a problem. But what you can see here are very, very faint collaterals going to the right coronary artery. Let's move on to the next slide, where we will show the angiography of the right coronary artery. And you can see in the right posterolateral branch that there is an occlusion, which is better visible on the next run, on a different projection, where you can see an occlusion of the right posterolateral branch. I will give you a few seconds to look at this. And we move on. Yes, here you can appreciate better the occlusion of the small right posterolateral branch. Again, to the audience, how would you treat this 19-year-old woman? Would you put a stent in, go for percutaneous coronary intervention, or would you want to treat her conservatively? Let's start the poll. So an exact 50-50 split for PCI versus conservative treatment. Let's move on. So I will let you know what we did. We treated this patient conservatively, and she received a glycoprotein 2B3A inhibitor. No stent, no intervention was performed. And I will show you why this decision was made. So what was not entirely obvious in the emergency department bedside echocardiography, but what I would like to show now that this patient has an atrial septal aneurysm, which is defined as an excursion of the atrial septum more than 10 millimeters, and which is, of course, a hint that this patient has a PFO. This was indeed confirmed in a bubble study with a significant crossing of bubbles to the left slide. This was also confirmed using a TOE. So most likely, we think that this is not an atherosclerotic problem in this patient, but a thromboembolic one. This patient developed a CK of approximately 500 units. And now my question to the audience is, how would you treat this patient? Would you go for aspirin monotherapy, or dual antiplatelet therapy as a treatment for potential MI? Would you go for single antiplatelet and an oral anticoagulant because you think this is a thromboembolic problem, or would you either go for triple therapy in this patient? Let's start the poll. So the winner is single antiplatelet therapy and an anticoagulant, which was chosen by 57%. 23% would go for DAPT, and 13% for triple therapy, 7% for only aspirin. And my next question is, would you only treat this patient with pharmacotherapy, or would you offer this young woman, 19 years of age, a PFO closure? Let's start the poll. All right, vast majority would go 83% in total to close the PFO. Now, this patient was discharged on single antiplatelet therapy and a NOAC as suggested by the majority of the participants. But what happened 3 weeks later is you would suggest that this patient has an extremely low bleeding risk, 19 years of age, no comorbidities. But what happened to this patient that he developed very severe hypomenorrhea. She had to be admitted to the gynecology department, and she developed significant anemia of 8.4, but did not need blood transfusions. Now, would you, in the light of this happening, continue antithrombotic therapy, or would you drop one of the two substances? Would you drop aspirin, or would you drop the anticoagulant? The majority would drop aspirin, 62%, 34% would drop the NOAC, and 3% would continue therapy as it is. Thank you. Let's move on. So the gynecologist administered tranexamide acid for 5 days, which we'd like to do. And what we suggested is to drop aspirin, because we again were of the belief that this is rather thromboembolic and not an atherosclerotic problem, despite the patient developing an MI. So the patient received an urgently scheduled PFO closure, and she's doing fine now. So I'm looking forward to discuss this maybe unusual case of a young patient with you, and what you would have done differently or similarly as it was done in our case.
Very much, Miklos. That was an excellent case. I must say that we have seen similar cases here, and it's always interesting discussions that we have about these patients. I have had a couple of questions from the audience about your case. First one, why a GPI in this patient if you know it's possibly a paradoxical embolism? And why not NOAC only and not combine with aspirin when you start your medical treatment?
Well, to answer the first question, the idea was pretty obvious from the beginning that this is not an atherosclerotic plaque, but a thrombus that is developed through a paradoxical embolism. And as a bailout therapy in the presence of a thrombus, where you would not want to put a stent into a 19-year-old woman, the decision was made to try to dissolve it using a GP2B3A inhibitor. The second question, why not NOAC only? I think we have chosen a very diplomatic approach. This patient has what was anticipated a very low bleeding risk, and she did develop a MI. She did have cardiac enzyme. She did have a CK of 500. And so the decision was that she should not only be treated with a prevention for further embolisms, but perhaps could have some benefit after MI from a single antiplatelet agent. But of course, this is all without any data from a relevant number of patients that were treated like that.
I have another question here. Did you calculate the HOPE score? It's a question from Vuda, and the HOPE score is sometimes useful to take the decision of PFO closure, but what about the HOPE score in this case?
I'm sorry, we did not calculate it.
Yeah, I must say that we have used the HOPE score for many years. We were quite disappointed by the predictability of events with the HOPE score, and we don't use it anymore. It's very much linked to the age and not very much to the other risk factors for a new event in these patients. And of course, the risk is a risk of having a stroke most often, but sometimes it's an acute MI, and I must say quite often in the right coronary artery more than in the left. But very, very interesting case.